Welcome, everyone. I see we have a few people who are attending on the webinar, so great. I just want to make sure everyone can hear us. So if you're watching on the webinar, give us a comment or something. And to my Revitalized Tribe, we have Dr. Lorraine Maita. So we're together in a mentorship, a group of practitioners across the United States who are committed in bringing you the most cutting edge functional medicine. And we recently connected because we have similar interests. So we were talking about all things hormonal, and we decided to kind of brainstorm and spread the word about hormone therapy. So when we were trying to decide about what to talk about, we settled in on talking about the myths of HRT. Susan says, hello. Great. Hello from Pennsylvania. So Lorraine, I'll let you introduce yourself. Tell us a little bit about yourself to my tribe so they can know a little bit about your background. You have a really interesting story.
Yeah, well, I started off in the emergency room in Midtown Manhattan, New York City, so there's almost nothing I haven't seen. And then I decided, because I saw people come back with the same thing over and over again, I wanted to focus on prevention, and I wanted to write and teach and speak and help people not have to keep coming back to the doctor. So I ended up getting a job in a corporation, and I wasn't sure if I was going to like it or not. And, you know, I worked my way up from a staff position to chief medical officer. I had 120,000 people, and I had at that time women come into me. That was when there were very few women executives, and they came into me desperate. They said, oh my God. I mean, I was really young then. I didn't know what PMS was or perimenopause or menopause, but they would come into me and say, you have to help me. I'm standing in front giving a presentation to these men all in suits, and I'm there dripping in sweat and flashing, and I lose my train of thought, and I see people chuckling in the background. Nobody can take me seriously. So this was back in the 80s, and I was studying bioidentical hormones with people in New York City, and I said, you know what, I'm going to help these women. And I saw the difference between the women who were on Prempro, which was a popular thing at the time, and it was almost malpractice not to give people these synthetic hormones. And then I kept prescribing bioidenticals to the women. And then they would come into me and they'd say, hey, I want what she has, because they'd see that there was a big difference with the way they responded. And, you know, then fast forward, I went through my own hormonal hell and started on bioidenticals, and I've never looked back. And, you know, I am a nerd. I study constantly. I've been certified by so many different organizations so that I'd have more tools in my toolbox.
And so your practice is in New Jersey, so you're a more urban setting, would you say?
Yes, much more urban. I'm very close to New York City.
Very close to New York City. So we are in the Midwest, and what would you say the general feeling is about hormones with women? When they come in, are they like, I don't want to take hormones, hormones cause cancer, or are they more like, I want to take hormones because I want to stay young? What's the general feeling, would you say, in your
I say 50-50, because most people find me through referrals from other patients, or they Googled. And actually, I have a lot of men that find me for their wives. It's very interesting. They will research the symptoms and say, you have to see her. And then I have other people come in and they're skeptical. They're like, well, help me. And I need to understand what they're all about. I'm not sure. There's a lot of fear around hormones. And I say the people who really want them come in, say, I want hormones. I know, I read, I understand. And those that they're on the fence, they want to learn more about it. And that's kind of the conversation that we had, because it's very refreshing to see a gynecologist who's knowledgeable in bioidenticals and who does a lot of hormone replacement therapy in the same way.
Okay, great. So Susan, let me know if the volume is any better, because I've got a comment that my volume isn't very low.
Is my volume okay? I mean, I don't know.
Sounds okay to me. Mine, I'm supposed to be, let me see, make sure my microphone is, yeah, I'm using the same microphone as I usually use, but thank you. Let me know if it's a problem. I can talk pretty loud. So we came up with 5 myths. And so the first one that we came up is will hormones make me gain weight? So what do you think about that, Lorraine? Can you comment on what you tell your patients about that?
Sure. To me, it's all about balance. Hormones don't make you gain weight. Your lifestyle and your diet makes you gain weight. If your hormones are balanced, I mean, I always do this with my patients. If your estrogen and progesterone are balanced, you feel good. If estrogen is high in relation to progesterone, which is where the perimenopausal women come in, it's called estrogen dominance. It doesn't even matter how high it is. It's the spread between the two. Because we know when you start running out of eggs, you can't make progesterone, which is the hormone of peace and calm and pee, and allows you to release fluids and to not gain weight. So when you have this imbalance, estrogen dominance can make you gain weight, but when we balance you and give you progesterone or lower the estrogen, your weight is normalized. So that's why a lot of women, I used to say, they feel fat, flabby, flaky, foggy, fatigued, and forgetful. And it has a lot to do with the hormone imbalance. So once you balance the hormones properly and you understand that what you eat, what you drink, how much you sleep, how much you exercise, the stress you're under, the toxins you're exposed to, they're all going to affect your hormones, so that if you take care of everything around it, you're not going to gain weight. In fact, most of my patients lose weight. What's your experience, Tara?
So I would agree that, so there's a misnomer that if you take hormones, you'll put on weight. And what I think that comes from is back when everybody was taking Prem-Pro,
Yeah.
and specifically women that had a hysterectomy and they were only given Premarin. So those women I saw put a lot of weight on. So there's a difference between Prem-Pro and Premarin. It's a different type of estrogen. Like Lorraine said, it's a synthetic estrogen. So it is metabolized in our body much differently than our own endogenous estrogen or something bioidentical, which, let's clear up the term that bioidentical, all that means is the chemical structure is the exact same as our own hormones that our body makes. So for example, we could say that sugar or glucose is the same that our body has, but Splenda is an artificial sweetener. So if you had a patient that was a diabetic who had a very low blood sugar, would you give them Splenda? No, because Splenda won't raise their glucose before they go into a coma. You'd have to give them what their body needs. So somewhere along the line, and this is the story that I always tell my patients. So we started out in the 40s giving bioidentical estrogen and bioidentical progesterone, and they used injections. But what they found out is that it took 2,500 pregnant pig ovaries to make 1 milligram of progesterone. And we normally give 100 every night. So they figured out that if they collected urine from pregnant horses, they could isolate an estrogen-like component, and that's where Premarin came in. Well, what we did then in 1942 was the most prescribed drug ever, and they started giving it to everyone because it was really a marketing ploy that they said, if you don't take these hormones, you're going to turn into a man, and you can be feminine forever, and you can spruce up your vagina. I mean, it was really, really sexist, because you know who was writing that marketing campaign. What they found in the 70s then is that there was an increased risk of uterine cancer, because they were only giving one of the hormones that our body makes, and they were giving a synthetic version that at the time we didn't know our body doesn't break it down at the same rate. So they went back to the lab and they tried to make progesterone, but they didn't have the technology at that time to make it, so they made a synthetic version, and all they were trying to do is counteract the estrogen stimulated growth in the uterus. So in the uterus, it did counteract estrogen. But in the breast, it does the opposite. It actually promotes growth. So that got all kinds of problems. So going back to the original question is, will you gain weight if you take hormones? I agree with Lorraine. If your hormones are out of balance, you'll gain weight. So if you have too much estrogen and not enough progesterone, and we see that in perimenopause a lot. We see women in menopause that still make a lot of estrogen because they don't get rid of it properly, or because they have it in their environment and toxins, like she said. There are a lot of hormones that can cause your weight, though. Having too much estrogen can affect your thyroid. Having a lot of stress can affect your insulin. So I agree that when I get patients hormonally balanced, they do end up losing weight, and they can't lose weight when they're not hormonally balanced. So they actually did a study on rats, and they took their ovaries out and they gained weight. And they figured, well, they're just eating so much, so we'll restrict their chow. And guess what? They still gained weight and they didn't move because they didn't have any energy. So it's like Goldilocks. Too much will make you gain weight. Too little is going to make you gain weight. So I agree. And the tricky thing is every woman has their own sweet spot for estrogen. So what my sweet spot is, isn't what my neighbor's sweet spot is, isn't what my other neighbor's sweet spot is. So that's why there's some biochemical individuality. So if you are taking hormones and gaining weight, you might not be on the right kind for you. You might not be on the right dosage for you, or it might not be monitored the right way.
Absolutely, because I have my patients who I get them balanced, and then I actually have a lot of doctors' wives, and then their husbands want to prescribe it. Why do you need to go to her? I'll prescribe it. And then they'll come back a few years later and say, oh my God, please help me. I just don't feel right. Something's changed. My husband doesn't know how to manage this. I need your help. And it's exactly right, because some people clear their hormones quickly. Some people clear them slowly. Some people don't really, they reabsorb them. There's so much that goes into hormonal balance that it's very different. And my own hormone challenge was when I went through perimenopause, I wasn't really able to prescribe for myself at the time. And I went from doctor to doctor, and they only had one way of doing things. And it just didn't fit me because I was extremely sensitive, and the doses that were made just didn't fit my body. It was just too much for me. I was extremely sensitive, and obviously from after learning a lot more and doing a lot of testing, I realized I was just reabsorbing the stuff, and I just wasn't very good at getting rid of it. So I ended up going from doctor to doctor and having one problem after the next until I finally just found somebody who would work with me, and we customized it. It's a difference between one of those one size fits all where it never really quite fits versus customizing it. And, sometimes I have many compounding pharmacies that I work with that tailor it to the exact person's needs. It's not one size fits all, and that's really a misnomer. So when you get it right, it's a beautiful thing.
I agree. And I think a lot of medicine is going towards this personalization. So everything's personalized now, right? I mean, your emojis, your Bitmojis, you can do whatever color skin you are for whatever. Everything is getting more and more personalized in general, in business, in medicine. I think it's great that we have the capability of finding out about your biochemistry. So I agree with you on all of that, that the balance has to be right, and it's a very complex thing. So we both agree that taking the right hormones for your body will not make you gain weight. And having an imbalance in hormones can make you gain weight and make it difficult for you to lose weight.
And I also found synthetic hormones made people gain weight, because when I was back in the 80s, when I was comparing the people with Prempro and the people on bioidenticals, the people in Prempro were depressed, they would gain weight, they were spotting, things were just not right. And a lot of those women on Prempro saw their colleagues, and they would tell them, go to Dr. Maita, she's going to help you. And they would come in and say, I want what she has, because there was a dramatic difference with the way they responded. And I even knew that from myself. I was never able to take the birth control pill because I gained weight and got depressed, but they're synthetic. That's what we have to get across to people. They don't know the difference between synthetic and bioidentical, and also the press doesn't make that distinction. So you have to be a detective.
Right. Well, I think we'll get into that myth number 5. So the next myth is, do hormones cause cancer? Because that's one of the biggest things that people are worried about, because, the study was done 15 years ago in a synthetics study, and now people still remember that. And I would say even primary care doctors in my area still think that. So how would you answer that to your patients?
Well, I study the study, so all of you out there don't have to, because I'm on the hormones and I have 1,000 people on the hormones. I took an oath, and I take it very seriously, because I do not want to do any harm. And when you look, even I write for a lot of magazines, so I had to write an article for Life Extension magazines, and they put me through extensive legal review. I had to prove every word I was saying, and I had to back it up with study after study after study. And you know, every year I do an advanced endocrinology course, and I just make sure I'm up to the date with the latest literature. So when the principal investigator of that Women's Health Initiative study came out, and in 2017, he wrote an article saying, you know what? They hijacked the study. They just jumped to conclusions. They didn't really consult the investigators. And he wrote an article in, you know, mainstream medical journal saying this study was designed to see how long after menopause does estrogen work. But they've taken that data and they've sliced and diced it and looked at it in many different angles. And what they found was estrogen alone decreased the risk of cancer. I'm going to repeat that. It actually decreased the risk of cancer. And what they found was in the EPIC studies and many studies afterwards with bioidentical progesterone, that's natural progesterone, there was no increased risk of cancer. So now they're stating, well, you know what it may be? It's a synthetic progestins. And that's really what's been implicated in the increased risk of cancer. The other thing is cancer is not genetic, except in few circumstances with the BRCA gene. It's mostly lifestyle. But most of the studies done on bioidenticals have not shown an increased risk of cancer. And there are studies that had people on hormones for over 18 years. So that's another question I get is how long can you be on them? But I have not found anything subsequent to that study, and even from that study, that showed that estrogen causes cancer. I don't know what your knowledge and expertise is in that area, but I know I've sent to gynecologists loads and loads of abstracts of papers just because they don't really study it in the way you do and I do, because this is what we do all day, every day. And that's only a very small slice of what they do.
Right. So the WHI study, which was published in 2002, did set out only to see if we should give everyone Prempro to prevent heart disease. That was the primary objective. And so when they did that study, they had to exclude anyone who was currently having any menopausal symptoms. So the average age of women was 63 in that study. So they had about 16,000 women in that study. And they had one arm of women who did not have a uterus because they had a hysterectomy that they gave estrogen only, and the other arm of women who did have a uterus, so they gave Premarin and Provera, which was called Prempro. And after about 5 years, it was suddenly stopped because they show an increased risk of blood clots and an increased risk of breast cancer. And so that unfortunately was on Good Morning America before it made into any of our professional journals.
Yes.
So if you break down that study, you have to look at a couple things. First of all, let me back up and say that the number one killer in women is heart disease. Number 2 is stroke. Number 3 is lung cancer. Number 4 is breast cancer. If you add up 2, 3, and 4, you still do not equal the number of deaths from heart disease. So statistically, you have a bigger chance of dying of a heart attack than you do of breast cancer. The statistics go further to say that the death rate 2 years after a hip fracture is higher than 10 years after breast cancer, but everyone fears cancer for whatever reason. So you have to put it in perspective that the studies on estrogen have all been very positive on cardiovascular. But having said that, you referred to, I want to just clarify one point that you said, just in case people didn't catch it. You did say that in the estrogen only arm, in that particular study, there was not an increased risk of estrogen. But there have been 2 other studies that if you give estrogen alone, it has increased the risk of cancer. So we don't recommend giving estrogen without progesterone.
Right.
Estrogen is a hormone that causes growth, and progesterone causes cell death. So you have to have the yin and the yang, the growth and the death. And if you don't have that balance, you're going to have unregulated growth. So the E3 EPIC cohort that you said that was published in 2008 was actually 80,000 women. And what they found in their initial publication in 2005, there was a protective effect with the bioidentical progesterone. And in 2008, what they found is there was no increased risk of cancer in women 40 to 64 using bioidentical estrogen through the skin and micronized progesterone for 8.1 years. But there was an increased risk in women who use a progestin and there was an increased risk in women who used estrogen only. So there was an increased risk of breast cancer in that study. There was another one that was in the Lancet. So I think the issue is there are a lot of factors. Now, I would add, piggyback onto what you said about lifestyle, is that we do see people in our practice that have a problem getting rid of estrogen. So if they're not detoxifying estrogen, we call that methylation, because I see a lot of breast cancer patients after their diagnosis, and I test all of them. And so I would say up in the 90% of them have a problem with methylation, and that's usually a genetic issue, a genetic, not a mutation, but so that their enzymes that are their drain per se of estrogen does not work great, right? And so they're accumulating estrogen, and so then they are unbalanced. But again, if you're not testing hormones and you're not seeing what the levels are, then that can be a problem. So I think we both agree that we do not feel that hormones cause cancer. So the next question is, it's confusing as to how to take estrogen. How should we take estrogen? So what is your answer to that, Lorraine?
Study after study show that if you take estrogen orally through the mouth, you get clots because it goes first pass through the liver. However, people may not understand how the FDA does labeling requirements. I mean, I happen to have worked in a pharma company where they made hormones, so I had to learn a lot about hormones. You know, my husband works in research, and he knows all about FDA. I mean, I don't really follow that, but all the studies that showed estrogen given through the skin, there is no increased risk of clots. They use the word negligible because you can never say never in medicine, because you can have clots from other reasons, but estrogen given through the skin does not cause clots. Now, understand that the FDA, when there's a class of drugs, so they started with oral, the first bioidentical hormones used they were oral estrogens, right? So people were taking them, and that's what caused the increased risk of heart attack and stroke. Think of that Women's Health Initiative. 10 years past, most of them were average age 63, 10 years past menopause, and they were taking high doses of synthetic hormones orally. So by that time, they've lost bone, they've lost memory, their arteries got stiff and hard, and they formed plaque. Then you add this oral estrogen, and it's forming clots on top of those plaques. So it did increase the risk of heart disease and stroke, and that's why they stopped the study. But when you started within the first 5 to 10 years, you don't have that. And if you give it through the skin, you don't have that. In fact, any study done with transdermal, meaning through the skin estrogen, has not shown any increased risk of clotting. And what the FDA will do, because my patients ask me, sometimes I give them a patch, and they'll read a side effect as increased risk of blood clots. But estradiol, whether it's given orally or through the skin, what the FDA will do, that's the same class of drugs. So they're going to take the label from one and put it right on the other. But subsequent studies showed that that is not really the case. But just to CYA, just to be legally sound, they have to publish that it's a potential risk.
Yes, so I completely agree. There were several studies that showed that if you take the estrogen early at the time of menopause, it's heart protective. And that's a general recommendation from the North American Menopause Society, that the benefits are better within the first 3 years of menopause. Although between 50 and 60, the benefits still outweigh the risk. And remember, those studies, a lot of those are done on synthetic hormones. But having said that, yes, there was another meta-analysis that looked at 17 different studies, and they all agreed that oral, not transdermal, was the one that increased the risk of blood clots, because, as Lorraine said, it has to go through the liver, and it increases a protein, the blood clotting. It also increases an inflammatory protein called CRP. But there's even more reasons why I don't like to give oral estrogen. One is because there's 3 types of estrogen. One is estrone, estradiol, and estriol. And if you even take a bioidentical estradiol and you take it orally in your gut, it's going to be conjugated to estrone sulfate. And we know that that type of estrogen has a higher affinity, so it likes to stimulate breast growth and uterus growth. So most of us make plenty of estrone from our adrenal gland and in our fat cells, so we don't need to give more estrone. The other reason I don't like to give it is because whenever you give oral estrogen, it increases something called a binding protein. So there's different types of binding proteins that transport your hormones. So as a result, if you take oral estrogen, you're essentially decreasing the free amount of your testosterone and your thyroid. So you're already causing a problem with those hormones because now they're going to be bound much. Bound hormones are like taking your paycheck and putting it all in your 401k. And so you have it, but you can't use it. You can't access it. And when you get your paycheck, you want some to go into your checking and some to go in your 401k, but not all of it. So that's another reason. There's even been studies that show that taking oral estrogen can interfere with your serotonin metabolism, and serotonin is your feel-good, happy hormone. So there's a lot of reasons why I don't like to use it. Clotting is definitely the biggest one. Now, there just came out, the FDA just approved a bioidentical oral estradiol in combination with micronized progesterone combination pill. So I'm conflicted because I've been asked by several people, are you going to write that? And what I say is, okay, if my market is the people coming in wanting bioidentical hormones, it's definitely going to be transdermal. But if it's someone that is a traditional doc, I'm trying to convince them and I just want to get them off the Prempro, yeah, I mean, it's a step better than Prempro because it's bioidentical progesterone, but it's oral estrogen. So that comes with its risk. So my preference, I agree with you, is to always write transdermal. I do have a couple patients for other reasons that they cannot take transdermal. So sometimes I'll use like a melt in your mouth. It's called a troche, and really advise them, make sure you melt the whole thing and you're not chewing it and swallowing it, because if you chew it and swallow it, it's oral. If you melt it under your mouth, it's called sublingual. So I agree.
Have you used the vaginal estrogens?
I use vaginal estrogens a lot, but they're not really great for systemic absorption. So I know there's some fans of what's labial applications and vaginal. So for tracking them, some people do get systemic symptoms and relief from vaginal estrogens. From a practical standpoint, a lot of my patients just don't want to be drippy and apply it that way. So it's much more convenient, like you said, to wear a patch or put a cream on. But there have been some people, that would be an option. There are actually commercially available bioidentical rings of estrogen only that I have a couple people that they insist. So it's definitely a challenge because obviously you have to match their levels, their needs, their budget, right? And so that definitely has something, because someone here is commenting, I'm going to assume a hormone special isn't covered by my insurance. So they're actually, a lot of them are not, but some of the testing and some of the medications, traditional blood tests can be covered partially. But you're right. I mean, because it's such a specific niche and the insurances generally doesn't reimburse the time that's required to spend with the patient to go through all these risks. All right. So the next question is, should estrogen be given alone if you don't have a uterus? So I kind of touched a little bit about my opinion. So why don't you share your experience about that?
Well, I've had the same experience. In fact, just a few weeks ago, I had a husband, well, it was about a month ago or 2 months ago. Husband found me for his wife, and she was miserable because she had a hysterectomy and she was on estrogen alone. And she gained weight and she was anxious and irritable. I tell people estrogen is a hormone of energy and growth. So energy out of control causes anxiety, irritability, insomnia, impatient, snappy behavior. It's like PMS and fluid retention. And she was absolutely miserable. Plus she gained weight and she was losing her hair, and she just felt bad because she just would snap at her husband, and her husband really wanted to help her. And he came with her, and it was really very touching because, when I explained to both of them that a lot of these issues were due to her hormones and I could help, I mean, she burst out in tears. This was just, she wanted to feel like herself again. She wanted help, and her husband was just so grateful he wanted to help her, and he was there asking so many questions, and he was reading. And so this is exactly what happens when women are on estrogen alone, and I get many of them. But the minute you put them on some bioidentical progesterone, and I like to give it orally, because when you give it orally, it metabolizes to something that is very calming. It works on the GABA receptors, which just calms your brain down, and it allows women to sleep and relieves anxiety. I saw her maybe 3 weeks later. She was happy, her husband was happy, she lost weight, she could sleep. She felt like herself again. She even did a video testimonial because she just said, she can't believe the difference. But it's doing a disservice because people don't realize that there are progesterone receptors in your breast, there are progesterone receptors in your brain. People are actually using progesterone after a stroke because it protects your brain. And how do you feel after not sleeping? You know, if you go night after night without sleeping, you're irritable. And it's not sleeping messes up all of your other hormones. Growth hormone raises cortisol. It wreaks havoc with your body. Just to bring all of that into a sense of calmness and balance, it's life-saving. And I've saved a lot of relationships and marriages and jobs just by giving women a little bit of progesterone. And it saved me, and it saved my relationships and my job too, because I was pretty irritable when I lost my progesterone and I was making estrogen alone.
Yes, for sure. I mean, I completely agree when you say about the progesterone receptor in every cell. We know that because when women have breast cancer, there's always a report about estrogen and progesterone receptors. So we know there's an estrogen and progesterone receptor in every cell in your body. So it would be as if you were just going to eat meat and no fat and no carbs. You know, you need protein, fats, and carbs in the right blend. So you need all of your hormones in a balance. So whenever I'm teaching my course, I always tell people, now, I used to be one of those gynecologists who said, because that's what they teach us, if you don't have a uterus, you don't need a progestin, which is true, because the progestin is just protecting you from the harmful estrogen, but you need progesterone. So I say to people, I don't know, I haven't operated for about 5 or 6 years. Has anything changed when you remove the uterus? Are you doing a bilateral mastectomy? No, you're not. You're still having those tissues and that are prone. So by giving estrogen only, you hit a lot of symptoms on the head, Lorraine. But my big issue is the risk of breast cancer. But you're right. They don't sleep well. Then you're giving a growth hormone, and they're usually gaining weight. So I'm glad to see that we both agree on that. So the last myth that we kind of came up with, probably the biggest one, is what is the difference between a progestin and a progesterone? So how do you like to explain that to patients?
Well, I just say, is a trans fat the same as a regular fat, as an omega-3 fat? No, they have very different effects. Just like you use the analogy, are artificial sweeteners the same as natural sugar? No, they act completely differently. Our bodies were designed with enzymes to break down hormones that they recognize. I mean, these hormones didn't exist. These synthetics did not exist. Progesterone has very different effects than natural progesterone. In fact, in my experience and with reading all the papers and going through all the courses that I've gone through, I found that women got more depressed on synthetics. They gained more weight. The synthetics caused cancer, and that's why I never give estrogen alone, even if without progesterone, but I only give bioidentical progesterone. There's only one instance where I would ever give a synthetic progesterone, and that's when somebody is really hemorrhaging and bleeding and they can't stop. A synthetic progesterone will really stop the bleeding. That's a short period of time. You do what you have to do, and then you go back to the bioidenticals. But what really gets me angry is whenever you read a headline or a magazine article or you listen to the news, they lump them together. Just like all fats are not the same, all hormones are not the same. So when they say, oh, progesterone causes cancer, are they speaking about bioidentical natural progesterone? If it doesn't say progesterone and doesn't have any other synonym, acronym, suffix, or prefix on it, then it's synthetic. And that's really where you have to be educated and be your own detective and go back and look, what did they actually use? Because I don't like the fact that they lump all of the hormones together and they're totally not the same.
And you brought up a good point as far as how it doesn't fit or it doesn't act the same. So if we like to explain it to people, do you know how you have a valet key that will not do all the same things as your regular key may? It may start your car, but it won't open your glove compartment. So it fits into the lock, but doesn't turn it. So that's like a progestin. It fits into the receptor, but doesn't have the same action as bioidentical progesterone. Or maybe it fits in and it doesn't fit in exactly the same. So there's definitely a difference. And one of the ways that I also explain is that if you actually look up the category of safety of progestins and progesterone in a pregnant woman, for example, we actually give progesterone in the first trimester for infertility patients. We give it in the second and third trimester for people who have a risk of preterm labor. So if they were the same thing, we could just use them interchangeably. If you look at the category safety of progesterone, it's safe in pregnancy. If you look up progestin, specifically Provera, it's category X, which means birth defects, don't give it, right? So if it were the same thing, it would be safe to give to a pregnant woman with our unborn child. So if it's so toxic that we don't want to give it to someone who's pregnant, why are we giving it as replacement year after year after day for women in menopause when they're clearly not the same thing? They don't do the same thing. The only thing it will do is thin the lining of the uterus and counteract the stimulation from estrogen. But it doesn't turn, it's not a precursor to testosterone in your normal cascade like progesterone is. That's why women get hair loss, because progestins can cause hair loss, causes water retention. That's why they gain weight. And as you mentioned before, progesterone stimulates the GABA receptor, which is a chill pill or antidepressant. So you're not getting that benefit with the progestin, and that's why it causes depression. So it kind of throws everything all out of balance. So I really think that we covered a lot of the main kind of points that I hear and questions I hear. Is there anything else that you can think of, or maybe anyone who's listening on the webinar, or I'll look to see if anyone's made any comments on Facebook? Anybody else have any other question that they want to ask us about hormones? Or Lorraine, can you think of anything else we didn't cover?
Well, I want to ask you, because I get a lot of flack from gynecologists in my area. Not all. I have my select few that we agree to disagree, but they, over time, they saw that I was not a crazy woman. I really took good care of my patients, and we can have a dialogue about them. Can you tell us what, because I know, and I love my gynecologist friends, and I know a lot of them said to me, listen, we are under so much pressure, and we have to deliver babies, and we have to do surgery, and we have to do so much. We'd rather you take care of the hormones, because that takes a lot of time. But some of them are kind of naive. I had one actually yell at me, and she said to me, how do you know what to prescribe? I said, well, I've been doing it for over 30 years, and there's prescribing information. And I studied under at the time, he was one of the world's leading gynecological endocrinologists, because that's what I was going to go into. And I just changed my mind about it. And she just kept pressuring me and said, well, this is not FDA approved. And I happened to have her patient on Prometrium, which is FDA approved, and estradiol patch, which is FDA approved. So I could say, well, it's in the PDR. And no matter what she came out with, I had a response, because she didn't know I've been studying this since, medical school and in depth. But I am amazed that a lot of gynecologists don't really know as much about hormones. Can you speak to what's in traditional gynecological training? about hormones.
Nothing.
Yeah.
So we learn how to cut a baby out in under a minute. We learn how to take a uterus out. We, the at least where I trained, we have to learn about the menstrual cycle for our test. There's only a few questions, and there's also a few questions. So I'm actually medical director at Suma Health, which is our hospital, and I do lecture the residents on hormone health. And so they do get, and I probably do about 5 lectures. So they do get some hormone training. They were rotating in my practice, and I'm not currently doing that right now, but so just to expose them. So we go by Spiroff's reproductive endocrine and gynecology, and if you look in there, everything that we're saying is in there. And I
Yeah.
quote that book when I speak as well. And so we don't really get very much menopause training at all. It's very OB heavy, and it's very gynecology surgery healthy. So the clinic patients that we're seeing are not coming in for hormone replacement. They're mainly younger. They need contraception. You know, they have STDs. They have irregular bleeding. They get a hysterectomy. And then you're really limited with those patients because you have to go on their formulary for what's covered if you're dealing with Medicaid patients. So all that's on the formulary is probably like Prempro. So we get almost no training at all unless you're interested, like you said. So the amount of time that you and I have poured into studying this, I mean, I have paid more than I paid for medical school than I have
So,
for my functional and integrative training. And so I don't think people know that. And so, you know, as a former gynecologist, I was never offendable, but there are a lot of people who are offendable if this is their area. And so a lot of times too, I think, gosh, if as a gynecologist, I didn't know, how does this person who didn't do OB know? But this person has made it their life study like you have. So I think, you know, the way that I combated some of those initial comments, I probably didn't get as many because I am a OBGYN, but I did get some. I was under fire for the evidence of what I do, and you just keep your head down and you just keep responding with the data, and like you did, and the studies. And so a lot of what we do, I would say 95 of my patients are on an estrogen patch. I mean, I do have some patients on bias, but for convenience and for cost, a lot of patients want something that's covered. So
yeah.
the progesterone, you know, we always start with commercially available bioidentical progesterone. If 100 is not enough and 200 is too much, or if they have a peanut allergy, we have to go to compounding very frequently because there's not the array of doses that there is with bioidentical estrogen. So there's a lot of options for commercially available bioidentical estrogen. Doesn't have estriol, and it has a whole nother conversation, but you can put that in progesterone. So I do, you know, everything that I do, I make sure that it's evidence-based. And so I think you're probably in a little worse position than I am because you're not a gynecologist. So gynecologists will say that, and then just answer to them
I do.
what we said and the data. So
Yeah, and I have a lot of data, and I back everything up with studies, and I've been studying this longer than many of them were practicing.
right.
And people didn't know, like I worked in a pharma company, they made hormones. I had to learn everything about hormones, and we tested people like crazy because everybody was afraid that it was going to interfere with their fertility. And, you know, there's a lot of liability. But I want to leave people with that get away from the fear of hormones, because all the studies are showing there's so much more benefit. The benefits outweigh the risks. And even the menopause societies are now saying you should it's beneficial. The sooner you start it, the better. And it's not the dangerous stuff that people have been told.
We do actually have a couple questions. So the first question is, describe your instructions to patients how and where on the body they should apply their transdermal creams. So do you want to address that?
I tend to have them do it on the inner arms, inner thighs, maybe the sides of the body, the upper chest. It depends on which cream. Some of them are lipophilic, meaning they like the fat and they can stay in the fat as a reservoir. Now, I used to see some do-it-yourselfers because there were docs that were telling people how to do it themselves and buy tests for themselves, and they would do it, and then they'd come in like giant puffballs, not doing the right thing, and they really couldn't eliminate the hormones. So I'm with you. You have to really know how a person eliminates the hormones to make it better and safer. And a lot of it has to do with the gut, and it has to do with their enzymes, and it has to do with their genetics and their nutrition. So I tend to do it on the thinner areas and not on the fatty areas, not on the face, not on the butt, not on the breasts.
Yeah, I agree. So that leads us to the next question, that is discussing the different types of testing. So I'm going to address this. So basically, if I'm seeing a patient that is still cycling, I will check blood levels, because what blood does is let us know what the ovary is producing. So remember that when you're looking at blood levels, you are looking at a bound hormone, not a free hormone. So there are some hormones in menopause that we can monitor via blood. If you're taking oral progesterone, now when I do blood testing, I'm very mindful about when they took their hormone and when I tell them to take the blood. Because obviously, if you have a graph of when you take progesterone, 1 hour, 2 hour, 3 hour, 4 hour, 5 hour, 6 hour, it's going to make a difference. So oral progesterone, you will see serum levels go up, and transdermal patches, you will see levels go up of estradiol. Not really the ideal way to monitor things, because blood is a highway and that's being transported. So what I worry about as a gynecologist and a hormone specialist is your body converting that to estrone, and what's the balance between estrone. So think about it this way. If you're a census taker and you're coming to my house to see how many people live here, right now I'm in my living room, my son's in the kitchen. So you'd say, oh, 2 people live here. Well, you don't know that I've got my husband who's out of town, I've got my daughter who's at play practice, and my other daughter is at Barnes and Noble. So you've only looked in one room of the house. So blood is only one compartment of the body. So for example, looking at saliva would be analogous through the studies since the 1970s of tissue levels. So they found that, you could do a biopsy of the ovary or a biopsy of the breast, or you could spit in a tube and the levels seem to correlate. Now, it's not an exact level, but it's more the ratios that we're looking at and the balance. So that would be analogous to if my daughter's leaving the house in sweatpants and I think, oh, she's so great, and she goes to school in her friend's house and she changes into a tank top and a miniskirt. I'm not seeing her convert to something bad out of my house. So when I give estrogen, if I'm just looking in the blood, you're not seeing in the tissue if somebody prefers to change that to estrone. So that would also be like if you're using a topical hormone and you're trying to measure blood levels. And this is a big issue that I just debated with at the national A4M level, some of the leading thought leaders in labs about my issue. So I'm going to state my opinion, which is backed by fact. But think about it. If you're putting a topical cream on, it goes on your skin, it gets through to your sub-Q layers, it's on the red blood cell for about 3 seconds. That has been proven. And so it goes through the capillary levels and then it's distributed. If we're measuring blood, we are measuring venous blood. Some of the studies specifically for progesterone shows that the progesterone is actually, once it goes to your tissues, it actually is excreted through your lymphatic channels. It doesn't go necessarily back from fatty tissue into the venous blood. So that would be like if you were a UPS driver and you said, I have too many packages to deliver, you have to cut my route down. And I said, okay, when you're done with your job tonight, come back to the station and I'll look in your truck. And you come back to the station, I look in your truck and I say, there's not that many packages in there. And you say, but I already delivered all of them. So when we're looking for this hormone, it's already been delivered everywhere else. When we're looking at the venous blood, it's only going to go up. And if there's so much excess of hormone that it's going into the venous system to be excreted. So you cannot measure topical hormones with blood, period.
Yay.
I don't care what anyone says.
I agree 100%.
I did say patches, you can sort of get it. So that's the best thing. Now, what about
the estrogen patches? I do. We do this in the same way.
Yeah, so urine is a little bit different. Urine is metabolite. So again, let me compare these 3 types of testing to accounting, okay? If I go and get my bank account for my practice right now, all it tells me is at that exact point in time, how much is in my bank account. My credit card, I'm going to pay tomorrow. I might get more patient deposits. So how do I know what it is? It's only one point in time. So blood levels are one point in time. But like I said, we're very mindful about when we do it. So if I want a little bit more detail about, I might look at the credit card bill and what I paid
and I might look at the budget. How much did I spend for rent? How much did I spend this? But I won't know that unless I look at my receipts. So when my accountant's doing my taxes, he doesn't want to know what my bank account balance is. He wants to look at my receipts. How much did you pay your staff? How much was rent? So that's like looking at your receipts and your urine, your metabolites. So we're seeing what's coming out, and we're putting together the pieces of how you are metabolizing hormones. So that debate, again, remains, can you actually correlate serum levels for transdermal hormones? So there's recently a couple white papers published through Precision Analytical or Dutch labs, and I have reviewed those, and it does seem that you can get what's called a serum equivalent, but we got to be careful about relying on one type of testing. So Jim, in answer to your question, it really depends on what you're trying to find out. If I want to know, is someone converting to too much estrone, I want to do saliva. If I want to know if someone's ovaries working, I want to check their thyroid, I'm going to do blood. If I want to know if someone is metabolizing their estrogen, or if they're methylating, or if their detoxification pathways are working, I'm going to do a dried urine test. In our practice, we seem to rotate and do all three on patients. So we might do serum once a year, depending on what they're on. And we might do saliva once a year and then rotate it every other year with urine. Now, if it's somebody that I have a high index of suspicion that they don't get rid of estrogen, someone who has a history of endometriosis, a family history of breast cancer, a personal history of breast cancer, fibroids, anything that tells me they don't get rid of estrogen, we might concentrate mostly on the urine tests, not necessarily the salivary tests. So it's a very complicated thing, and that's why when patients come in and say, this doctor only said blood, only does blood, 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 I don't really agree with that. So again, you need to make sure that depending on what you want to know, because if you just said, here's my bank account balance to your accountant, how could they put any kind of meaningful information together, right? They want to know everything. They want to see what you paid your staff. They want to know what your rent was, what your expenses are on your P&L. You got to see it all. So that's I hope that answered your question. So Jim, I don't know if there's anything else. It looks like that's all the questions from there. I don't have any on my end on Facebook. Do you have any, Lorraine?
I don't see any of the questions because I don't know what kind of, this is the first, oops, hello?
Yeah, nothing?
Yeah, I can't see any questions, so I don't know whether only you get the questions or I've been getting the questions.
On your Facebook page? Okay.
Yeah. But one other thing I would mention, because I mean, the reason why I think we connected is we believe the same things, we do things the same way. I look at all three. I don't rely on any one method because like you said, you're just not seeing the full picture. I'm a little loath to dose somebody on just urine, but I definitely want to know the metabolites. And I think people should be aware of this study, and the analogy I use when it comes to urine. When you're breaking down your estrogen, it's like sorting the garbage. You can have your nice, clean recyclables, or you can have the dirty, stinky garbage. And there's the one in between, right? So when they did studies on women who didn't have breast cancer or didn't have a family history of breast cancer, and I've seen this play out in my practice, they made more of this 2-hydroxyestrogen, which is less damaging. It's not really as problematic as the dirty, stinky garbage, which is 4-hydroxyestrogen. Now that stuff is like a known intermediate metabolite, which is a broken down estrogen that can be damaging to your DNA. So think about it. If you have a superhighway going down to 4-hydroxyestrogen, and then you don't methylate, which is the highway narrowed down into 1 or 2 lanes, you get a backup of this toxic stuff, and you can't get rid of it. We need to know that. We need to know that because when they did studies, women with a family history of breast cancer or a history of breast cancer, they make more of that 4-hydroxyestrogen, and then their superhighway, they make a lot of that. They don't methylate, which is what puts them in the bag and gets rid of it. So we need to know that, and that's why I like the urine test, because it gives us a lot of information about how they metabolize testosterone, progesterone, estrogen, it gives so much information. And I usually do it when I know that they're making some estrogen, because I find that sometimes women will come in having done it at some nutritionist and they have hardly any estrogen. So it's like trying to figure out if this bridge can hold a lot of cars, but there are no cars going on it, so you can't really tell. So that's really why I like to do that a little later, and once I know that they have adequate estrogen. I mean, I don't know how you feel about
Yeah,
that.
I completely agree. Get them on treatment levels, do saliva, and then down the road, do the urine. So thanks for everyone who's spent part of your evening with us. We're really glad to hopefully get this out, and of course, it'll be both on both of our pages for people who weren't able to tune in. We'll both be watching the post, so if you have a question, even if this is after the fact, please put it on our respective pages, and we'll address it. And so hopefully, this will help clear up some of the myths and confusion. And thank you, Lorraine, for all you do and stomping out. I know I've sent your name to a couple people in your neck of the woods. I don't know if they actually made appointments, but we've had some patients on Instagram and reaching out to us asking for someone in New Jersey. So I pass along your name.
Well, I'll be passing on your name, and we have somebody in common that knows you. And when I told him I was doing this webinar with you, he said he couldn't wait to listen in. So
well, great.
We all have to support each other, because there are too many women out there suffering needlessly. That's the point I want to make.
Absolutely. So have a great day and enjoy the rest of the sun that we're having.
Thanks, everybody. Bye.